Good morning, everybody. We're here at last. So sorry for that technical hitch. I didn't think 70 of you wanted to present at the conference to open it, so sorry it took us a moment to sort that out, but we're here finally. My name's Dr. Polley. I'm co-chair of the Social Prescribing Network. Absolutely delighted to be with you here. Have I said Happy Social Prescribing Day 2022? Lots going on Twitter. So 6 months in the making, 530 delegates at the last count last night, 13 countries involved, and about 18 minutes sorting out technical hitches. But we're here and we hope we're going to have a spectacular couple of days with you. So I just want to take a moment to say the Social Prescribing Network, if you haven't already signed up to it, is a free network to sign up to. And we're grassroots and we're community and we're aimed at encouraging collaboration and disseminating information about social prescribing, no matter who's putting that information out. In fact, since we started 7 years ago, we put a newsletter out every month. I think that must be nearly 100 now. We are unfunded, and the money that we get from running this conference is what runs the Social Prescribing Network, and it pays for our website and the admin. So can I just say thank you for supporting our conference and supporting the network continuing. So we've invested in a website this year, a new website, and I'm really excited because it looks a lot better. So do have a look. We launched it at the beginning of Social Prescribing Week. And I'm really excited that on there we've put the first open access grey literature archive and repository for social prescribing information, because a lot of information and evidence is held in the grey literature at the moment. So if you've got a report that you've published from your organisation that's about social prescribing and you want to put it there, you can go onto the website, you can fill in some information on a form and you can submit it. And Sonia, the network coordinator, messaged me earlier and said we've just had the first submission. So I thought that was very auspicious for Social Prescribing Day. Thank you to whoever sent that in. Do send them in, we'll update it and it will always be free and open access. And also today we're just launching a database where if you've got research that's being funded, a project, we'd like to know so that we can find out and get a list and a Google sheet as well of who's doing what research. Then if you think you've got a research idea and you want to know if anyone's already doing it or there could be a collaboration that you could make, then please again submit this information and then it's another resource for our social prescribing community. Brilliant. So 3 years ago we set up the Social Prescribing Network Awards to celebrate all that amazing work that just happens day in, day out, nice and quietly. Really excited that we will be doing the awards this afternoon and we'll see who's won their awards. Thank you to everyone that submitted entries, but thank you to all of you for everything you do. Throughout the trials and tribulations of the last 18 minutes and of the last 7 years, I think the highlight for me has been working with all of you wonderful people. You're such a fantastic social prescribing community and you really care about that person who needs that support at that point in time. And I just feel very blessed that I get to work with you all. So thank you. So Michael, welcome.
Well, thank you, Marie, and I say yes to all of that. And isn't it wonderful to be back here with so many friends and enthusiasts of social prescribing? I co-chair the National Social Prescribing Network with Marie, and it's really wonderful to be opening this conference with you all. Of course, the last year has been, perhaps the last year or two has been the very best and the very worst of years, and I don't need to describe to all of you here the very worst of it. We've had the hokey cokey of COVID. 1 minute everything opening up, next minute we're all back being isolating. We've seen the growing inequalities. We've seen those increasing, rather depressing queues towards food banks. The lonely elderly have been particularly hard hit, but so too have our young people who have missed out during their most formative years. But these worst years have been balanced through social prescribing with some of the best. And the social prescribing link workers who have risen to the occasion, proactively contacting those who are in most need and giving virtual support where face-to-face wasn't possible. And in England, the last 2 years have seen an expansion of the social prescribing workforce through national state funding, and also some help for the voluntary sector through the Thriving Communities Fund of the National Academy of Social Prescribing. And throughout the country, the other very exciting thing has been the massive growth in volunteers, those volunteers who have been manning our COVID clinics day in, day out. Last week, I went down to Market Town in Somerset, Frome, where there were over 2,000 community connectors. These are people that are shopkeepers, they are hairdressers, they're taxi drivers, connecting the whole town to the volunteer and voluntary services. And internationally, we've also seen great progress, as we shall see tomorrow, in countries such as Finland, Canada, Netherlands, Singapore and Portugal, all supported by the National Academy's Global Institute for Social Prescription. And now, at least last in the UK, lockdown is over. The doors of our cages have been opened, and I feel a real sense of hope in the air now. And I see our conference over the next 2 days as building on that hope and enabling all of us, social prescribing link workers in particular, to start once again having those in-depth consultations that really make a difference to those that most need them.
Thank you, Michael. I think so. This morning we are going to be looking at social prescribing and inequalities. I'm delighted we have Sir Michael Marmot with us to help us through this. We're going to look at international and national perspectives right through to very local schemes that are there already making a difference. We aim to leave you in no doubt that social prescribing has a key role to play, reaching and supporting the most vulnerable people in our society.
And then later this morning, we're going to look at primary care and general practice and how it can support and connect with social prescribing and create healthy communities. And this is particularly relevant in the UK at present as we now undergo structural health service change in the move to integrated care systems and the pressing need to ensure that social prescribing within them is enabled to be ever more effective and can flourish.
So this afternoon, we are going to have the opportunity to go into different breakout rooms. These are rooms, there's 4 rooms, and these are subjects that have been requested by you, the social prescribing community, when we ask around and when we ask through the network what you would like to see at the conference. So I hope you enjoy those breakouts this afternoon. You will be able to click on the conference platform where it says posters and look at all the research posters that have been submitted. You can look at those anytime. And we're going to end this afternoon with our awards show. Thank you so much to Chamberlain Dunn for helping us with this. I'm really excited about that. Michael.
Well, as last year, we've got a networking lounge with tables that you can gather around to continue those conversations and an opportunity also to talk to our conference exhibitors. We're also looking forward to hearing poetry from Harula Ladd, our poet in residence. Harula will be visiting different sessions and turning her inspiration into words. And then we're going to end the conference by finding out your views on what you've heard and what you feel should go into the future with special polls. We're going to hear about personal experiences of some of those that have attended and poetry.
Thank you, Michael. So before we move on with the conference, we'd like to extend a really big thank you to our conference partners, National Academy of Social Prescribing and NHS England and NHS Improvement, the Personalised Care Group, who are really big supporters of our conference, and we couldn't do it without them, so thank you very much. I'd also like to thank all of our exhibitors that are with us. I'd like to thank our Social Prescribing Network Steering Committee, who are all volunteering work really hard behind the scenes, and the Conference Research Committee that looked through all of the research abstracts that were submitted and peer reviewed them and helped us select which ones were chosen for oral presentations. And thank you to the conference team for helping bring this together. And if I've not said thank you to anybody, actually, I'll just say thank you to Sonia El-Nashi, who is the SPN coordinator. Sonia has worked her socks off over the last couple of weeks as we've brought this conference together. So thank you to Sonia. So if I've missed anyone else out, I'm sorry, but can I just say thank you to all of you for everything you do. And Michael, I'm handing back over to you.
Well, please, yes, and do please ask questions via the Q&A and chat functions. As always, we invite controversial and courageous questions. I don't think the social prescribing movement has ever lacked any courage. And all I can say is that I'm really looking forward to a fascinating and inspiring 2 days, finding out what you've all been up to over the last year, and hopefully meeting some of you in our virtual meeting room.
Brilliant. So if you feel, if any of you feel inspired or moved or motivated, if you feel encouraged, then just please tweet. We are using the hashtag social prescribing 2022 for the conference. So over to you on Twitter. Right, Michael, I think miraculously we're back on time. So I'm going to hand over to you to take us forward with the programme.
Well, thank you, Marie. And it's my really great pleasure to introduce a very special person to you. He's Chief of Social Prescribing, both at NHS England and Chief Executive of the National Academy. He's a big hero of mine because he today, I would say, is Mr. Social Prescribing in England. And so it's a great pleasure to hand you over to James Sanderson. James.
Michael, thank you very much for that introduction. And oh my goodness, I'm not sure I can wear that title. I think the amazing thing about being here today is just seeing so many people that have joined this conference that are social prescribing leaders right across the world. And I just want to start by congratulating yourself, Michael, and you, Marie, on bringing the network together and maintaining it as a force for good to develop social prescribing over the course of many, many years. I think our responsibility as a social prescribing community has never been more important. I think there's an urgency now for us to ensure that social prescribing is part of mainstream health systems, not just here in England and the UK, but all around the world. Social prescribing, to me, can create a revolution in the way in which not only do that we view health and well-being, but actually we deliver health and support for well-being for people right across the globe. And I think this is important for a number of reasons. Firstly, as has been mentioned, the social determinants of health we know are so powerful in relation to how they impact on people every day of the week. And you know, I won't go on about this because we have the leading expert, Sir Michael Marmot, who's going to be speaking very, very soon about this. But if we consider some of the gross inequalities that we have in our society, you know, people developing long-term conditions 10 to 15 years earlier in the least affluent areas to those in the most affluent areas. And we see people dying 10 to 15 years earlier as well. We also see that whilst biomedicine unlocks the opportunity of good health and well-being in many circumstances and is a marvel of humankind that we've invented, we've created, we've developed so many opportunities to keep as well as human beings. If you think about, you know, what's happened over the last 100 years with the discovery of penicillin, less than 100 years ago, the development of vaccinations, the development of modern medical techniques as well, such as surgical techniques, the ability to scan the inside of people's bodies with MRI scanners and CT scanners and X-rays. You know, all of those developments that have happened over the last 100 years have really revolutionized healthcare. However, there are limitations. They don't impact on the social determinants of health. They also create problems for us as a society. 1 in 5 people over the age of 65 are in hospital, not because of the condition that they're living with, but because of the medications that they're taking. And when we look at issues across the world with opiate addiction, with antimicrobial resistance, we see that whilst biomedicine still holds a lot of keys for us, it has its limitations. And 1 in 5 people turning up to see their GP are going to see their GP not because of a medical need, but because of a social need. So the time is now for us to implement social prescribing at scale, because social prescribing cuts through these issues. Social prescribing creates connections and enables us as human beings to live healthy lives. The evidence is strong now. We know the impact of social activity on people. We know that it can reduce loneliness and social isolation. We know that it can deal with the pressing circumstances that people are facing, whether that's issues with housing, issues with debt, issues with relationships. You know, these are the things that are creating the circumstances through which people have poor health outcomes. And that is why social prescribing and the move to social prescribing is so pressing for us as a society. Over at the National Academy for Social Prescribing, we've been looking at championing this since the Academy was developed a couple of years ago, and we have a programme of thriving communities where across the country we're working with local communities to join things up, to create the opportunities for people working in the arts and creative space, to work with people in sports and exercise, to work with people using the natural environment, using information and guidance to improve people's lives. And we've brought these communities together, and there's a vibrant network across the whole of the country now that's doing fantastic work on a day-to-day basis. We're also championing the role of the link worker, and just to pause for a second and reflect on how amazing link workers have performed over the last year. Link workers will have seen close to 1 million people over the last year in GP practices right across the country during the middle of a global pandemic. Many of these link workers have started their careers, have joined in the most difficult circumstances, dealing and supporting with people with a variety of issues that they're facing in society. And link workers, to me, have done an incredible job and are at the heart of social prescribing. So thank you all for the amazing work that you do. And we've also developed a global alliance as well, working with the World Health Innovation Summit, the UNGSII and the World Health Organization, and working with the Social Prescribing Network. We've now got colleagues right across the world who are pursuing social prescribing in their own country. And I think this represents a true alliance, a meeting of minds, a universal world language where people can get behind this core movement. And I don't think there's many things like this, as powerful as this, that can unite people right across the world. So social prescribing for me can create a revolution in health and well-being, but more than creating a revolution, more than creating something new, I think we're now in a position where we can't afford not to move down this route. We can't afford as a society, as a global community of health, not to embrace the opportunity for psychosocial support sitting alongside biomedicine. We need a different focus in the way in which we deliver health and well-being support for people, and social prescribing for me is that focus. Thank you very much.
Just muted there, Marie.
I'll unmute myself. There has to be someone where you have to say, you're on mute. James, thank you so much. It's a real pleasure to have you with us. It's a real pleasure to work with NASP and collaborate, and I think there's a huge amount. Can you hear me okay, by the way? Yeah, there's a huge amount of work still to do, isn't there? We'll be busy for another 7 years at least. So we're going to move on, and I'm going to have a chat with Darren Dooler. So I'm just going to welcome Darren Dooler, but I think he's very much known as Daz. So Daz is known to a lot of people on Twitter, and Daz actually, in our Social Prescribing Network Awards last year, was a finalist in the Most Inspirational Person category. And actually, Daz has had a whole career as a mechanical and electrical engineer. He's worked his way up the ranks, studied, done degrees, done all sorts, found himself in need of social prescribing, and is now involved with expert patient programs. You've formed the SMASH Society, the Self-Management and Self-Help Society, and just put so much back into the community. And we just wanted to sort of start the conference with just centering ourselves back to what it is like to be a person using social prescribing. So I've got 3 questions for Daz, and I'm just going to say welcome, Daz. And
thank you.
My first question for you was, what led you to use social prescribing?
I think initially, and good morning everyone, such an honour to be here. I think originally it was ultimately desperation. I kind of tried everything else, and it's not over the top to say that without social prescribing and other things, I wouldn't be here now. My life had literally gone, my head exploded. My life was going down and down and down and down and down. My mental health was going down. I'd climbed the ladder at work. I'd got the success that I felt that I wanted, but then I just couldn't deal with it. And it was desperation that made me go to see my GP. And because I was considering taking my own life, and my GP introduced me to social prescribing. Now, when I originally got the access to social prescribing, the word social prescribing weren't necessarily being bandied around. So I'm from Wakefield in West Yorkshire. There was a process being put together through Live Well Wakefield and the local authority and South West Yorkshire NHS Partnership Foundation Trust. But I accessed social prescribing in that way. And I went on, you mentioned the Expert Patients Programme. It was recommended that I went on a course around my mental health called the New Beginnings course. And it introduced me to meeting people and being introduced to people that made me feel empowered to take control back. So I didn't want to continue being a passenger in my condition. I wanted to be the driver of that condition. And it's essentially made me go from saying I suffer with a mental health condition to I live with a mental health condition. That's very subtle, but it's very powerful as well.
Thank you, Darren. That is just, it's quite, well, it's very powerful to listen and hear you speak. And it's very honest of you as well to share your words with us, and it's very inspirational. I really like that move from I suffer to I live with. I think that, yeah, it just makes a massive difference, does it? What was it then in that, instead of just being given some medication from your GP, they could have just said, look, here's some anti-anxiety medication or antidepressant. What was it about this different approach then? Was there something that helped you become empowered?
Yeah, I think, and I did a podcast last year with Dr. Rada von Nasp, and I think what it is, a lot of people kind of know what's going on. They know what they need to do. They just don't know how to do it.
Yeah.
And the social prescribing link workers sort of engage with them in a manner that allows them to, right, I'm going to take you to the start of the path. I'm going to show you a few paths. Ultimately, you choose, but I'll meet you part way and see if everything's going as you would expect it to do. And then helping you along the way. You know, they're not doing it for you. They're allowing you to do it for yourself. And you make mistakes, but they will help you with those mistakes and point you back in the right direction. And I think that's what social prescribing does. It allows you to make those mistakes that previously would have been the end of the world, but actually they can help pick you up and put you back on that right path. Yeah,
that's a really great way of describing it. And having someone alongside you to work with that, who doesn't judge. I think something very special about link workers is that non-judgment.
I think that were it, because I think when you're dealing with, no disrespect to any clinicians, you know, my GP is amazing, absolutely amazing. My GP practice is amazing, but I think that you feel that you're being more directed and instructed rather than walking with. You feel that there's a general feeling that these people are superior to you. And again, I mean, no disrespect by that, but they understand the clinical side of things, but not necessarily the fear of when the envelope comes through the door from the Department of Work and Pensions, when the phone rings with an unknown number, when somebody knocks on the door and you're worried that it's somebody wanting something, you know, money, a favour, anything at all, and that absolute petrified thoughts that you have during these times. And the social prescribing link workers and the whole social prescribing teams just give you that little bit of, that little strength inside to say, you know what, I can do this, and if I get stuck, I can get in touch with them and say, I'm towing here, to use a Yorkshire terminology. I'm struggling with this. Can you just remind me where I'm supposed to be, what we talked about doing?
Yeah, I think that's so important, that just being able to check in and just say, actually, you know, I've got so far, I need a bit of encouragement now. So just my final question to finish off for the last minute or so. We've heard you come in through this quite difficult time, but I know social prescribing has had a big impact, or really the work that you've done through the help of social prescribing, I should say. So where are you now, Daz? What's the impact been?
Okay, so I left Livewell last year to become freelance, to start working for myself, but to support organisations in and around the Wakefield area, the Wakefield district predominantly, but also throughout the West Yorkshire Partnership, and also nationally. You know, obviously I meet people nationally through Twitter and forums like that, because even though I've left the actual social prescribing group within Wakefield, I'm still part of the social prescribing scene with Spectrum people who work with people in a particular area of the district, doing things like art therapy, poetry and exercise walks and those sorts of things. So I'm supporting that project. I'm also working with the Young Lives Consortium, who work with young people in the area, because as Michael indicated earlier, you know, young people have struggled. And you know, again, we've somewhat failed the young people, particularly in deprived, you know, the areas of deprivation like Wakefield, and it's not just Wakefield. There's areas all over the UK, and I want to use the skills that I've learned throughout my life, but also where I've learned recently through social prescribing and being through the process, to give something back, to enable other people to acknowledge that you don't have to. Mine's a long-term health condition. Not everybody's is. Some is a social situation, but it's not the end of your life. It really isn't. In fact, it's very much the start of your life. I am now the person that I always wanted to be, but never dared admit, because I always thought I needed to be what somebody else wanted me to be.
Oh, Darren, that's so powerful. I think it's beautiful when you can live the path that you want to live, isn't it? And
yes.
And feel safe to be that person.
Yes.
If we were in a conference hall, I think everyone would be cheering and clapping now, and that's the thing I miss the most. And I think there's a lot of people at home clapping and cheering, and I'm just so pleased you are where you are. And a massive thank you for opening the conference with us with your experience. Thank you so much.
Thank you. And thank you for asking me, and thank you to everybody for all you do. You are all amazing, and please keep doing it. I know it's hard at times, but please keep doing it, because you make such a difference to people's lives, and I'm an example of that.
Thank you, Darren,
thank you
so much. I was just going to say Daz, because I feel like
Daz
now it can be Daz. Right, I'm handing over to you, Dr. Michael Dixon.
Well, thank you. And Daz, that was absolutely amazing. And I'm certainly clapping very hard. You are an extraordinary ambassador and such a great communicator on social prescribing. Thank you so much for that. It's now my great pleasure to introduce Sir Michael Marmot, who actually really doesn't need any introduction. He's little short of a national treasure. I've just glanced back at my bookcase, so I can now advertise, Michael, your fantastic book. If you haven't read this, incidentally, this is the book that you need to read from tomorrow. Michael has written over and spoken over many years about social inequalities. His messages are never more relevant than today. And that's all I've got to say, Michael, because Michael can speak for himself more than I can possibly do so. And it's a real great pleasure to introduce Michael to this conference. Over to you, Michael.
Thank you. And it's an absolute pleasure to be here. Social prescribing really fits into the model of what I've been talking about these many years. Taking up your invitation to give a context in which social prescribing happens is what I plan to do. 2 years ago, in fact, 25th of February 2020, we published Health Equity in England, the Marmot Review 10 years on. As you may know, I'll go back 2 steps. I chaired the WHO Commission on Social Determinants of Health. We reported in 2008, and the then Prime Minister, Gordon Brown of the UK, asked me how we could apply the recommendations and findings of the Global Commission to one country, England. So I conducted the Marmot Review, which we published as Fair Society, Healthy Lives, with a set of recommendations of what needed to be done to reduce health inequalities. So in February 2020, literally the 10-year anniversary of Fair Society, Healthy Lives, we looked back at what had happened. And the news was not good. Life expectancy had been increasing about 1 year every 4 years. I've taken this back to 1980. I could have taken it back to 1890, and life expectancy was increasing 1 year every 4 years. In 2010-11, there was a break in the curve, and the rate of increase slowed dramatically, just about ground to a halt. Wow, if you were the government that was elected in 2010, you could say, wow, we did that. That's fantastic. No other government had managed to achieve that. This life expectancy increase that had gone on regardless of who was in power. And we changed the course of history. Well, that is a hubristic claim. Did they change the course of history? Was it the government that led to this slowing of improvement? And not just a slowing of improvement, but an increase in inequalities. This is women. If you look at life expectancy in the least deprived decile, the greater the deprivation, the lower the life expectancy. Take the least deprived 10%. Life expectancy was improving a bit, and the regional differences were quite small. If you're rich, it doesn't much matter where in the country you live. If you're poor, it matters enormously. Life expectancy for the most deprived decile went up in London and went down more or less in every region outside London. And the regional differences are much bigger for the most deprived 10% than they are for the least deprived. And to look at that in more detail, here's London and the Northeast. For the least deprived decile, there's very little difference in life expectancy between London and the Northeast. And then here's the gradient. The greater the deprivation, the shorter the life expectancy, and the disadvantage of being in the Northeast compared with London gets bigger the greater the deprivation. Or to put it differently, the slope of the social gradient is steeper in the Northeast than it is in London. Now that's really interesting. This is a national index of multiple deprivation, but the implications for health are bigger in the north than they are in the south and southeast. Now let's look over time. The dotted line is London 2010-12. And the solid line 2016-18, life expectancy improved in London across the gradient. For the Northeast, life expectancy went down for the most deprived decile, went down a bit for the next most deprived, and then for the bottom 5, 6 deciles of deprivation, there was no improvement. It's only when you get up to the upper 40% that you get some improvement in the Northeast. So that's where we were before the pandemic crashed. And then came the pandemic. I waited 10 years to do the Marmot Review 10 years on. I waited only 10 months to do the COVID-19 review. Here's the social gradient in mortality from all causes. The greater the deprivation, the higher the mortality. It's the other way around from life expectancy. And here is the social gradient for the mortality from COVID-19. It's almost identical to the social gradient in all causes. Some relative excess at the bottom, which we think is frontline occupations, overcrowded households. But it means, as we've said from the beginning, the pandemic exposed and amplified the underlying inequalities in society. And I want to deal with some apparent opposites as a way of shaping the argument. Should we take a social or medical approach? Now, whenever I put up these opposites, the answer is always yes. We should take a social and a medical approach. The health gap, thank you, Michael. The opening line of my book was why treat people and send them back to the conditions that made them sick. Particularly during a pandemic, we think a great deal about the healthcare system, but we also need to address the conditions that make people sick. I got the nurses of Northern Ireland to take the lead in producing a volume on nurses for health equity, guidelines for tackling the social determinants of health. In other words, social or medical, this is where social prescribing comes in. It's social and medical. Within the context of primary care, people's needs can be addressed in a holistic way. So it's social and medical. Disease control or social determinants. There's the social gradient in COVID-19 that I showed you a moment ago. To hear our politicians, they think the whole deal with COVID is about vaccination. Social distancing, gone. Mask wearing, gone. Any other precautions, gone. It's just vaccination. It's just control of the virus. But what about the social gradient? I was talking to a group of dentists, an international group on oral health, and I showed them this graph. It looks like COVID-19, but it's not. It's caries in 5-year-old children. An identical social gradient to the COVID-19 mortality. Then I was talking to a group on primary prevention in primary care. So I showed them this graph. Obesity prevalence in year 6 by deprivation. It looks the same as the COVID-19. What's going on here? We think that COVID's caused by a virus. We think that dental caries is caused by diet, low fluoride, poor oral hygiene. Obesity in children is diet, exercise, stress, not a virus. Yes, we need disease control. We need to control the virus. But what a simplistic, limited approach to the health problem. We need to deal with the underlying inequalities that lead to inequalities in the consequences of the virus, as dental caries, obesity in children. And if we're going to take a social approach, these were the 6 domains of recommendations that I had in the Fair Society Healthy Lives, the Marmot Review. Give every child the best start in life, education and lifelong learning, fair employment and good work for all. Wow, this is far more relevant. Having enough money, at least the minimum, to be able to lead a healthy life. Healthy and sustainable places and communities, and taking a social determinants approach to prevention. And that relates to social determinants or individual responsibilities. This is a Rorschach test of people's political leanings. If you're on the right politically, you think it's all individual responsibility. Poor people have only themselves to blame for their poor health. They don't listen to the good advice. Poor diet? No, I could cook. If they only would learn to cook, I could live on, you've heard all those upper class ladies spouting about how they could live if only those poor people knew how to cook and look after themselves. Well, what's the reality? The Food Foundation published this. For people in the most deprived 10% of households, for them to follow the healthy eating guidance, they would need to spend 74% of household income on eating, on food. 74%. Who's going to pay the rent? Who's going to pay for heating? Don't blame the poor, blame their poverty. Here's an evidence-based response to that debate. Targeted or universal? Everybody thinks it makes sense to target. Why waste money on programs for people who don't need it? Target. There's a principle of universal systems that we're all in it. You've heard the politicians say we're all in it together. That's complete rubbish, as you know. But a universal system really does mean we're all in it. The NHS is a universal system. So I tried to combine targeted and universal and talked about proportionate universalism. A universal system with effort proportionate to need. Here's the social distribution, let's say life expectancy. The less the deprivation, the higher the life expectancy. We want universal systems that deal with the gradient with effort proportionate to need. Here we are, we could call it levelling up. What an idea. I wonder if the government would think of such a thing. What did we get post 2010? Here's spending by local government by level of deprivation. For the least deprived 20% of areas, the grey bars, total local authority spending per person. The spending post 2010 went down by 16%. And then the greater the deprivation, the greater the reduction. In the most deprived 20% of areas, it went down by 32%. What we've got here is effort inversely proportionate to need. The greater the deprivation, the greater the need. The greater the need, the greater the reduction in spending. Could that have played a role in the slowdown in health improvement, the increase in inequalities, the decline in life expectancy in the poorest areas? Yeah, I think it could. Unless you work on the assumption that all public spending is a waste of money, that public expenditure was doing good things. Take it away, life will get worse. Life gets worse, mortality rates will go up, life expectancy will go down. Central or local? The whole point of social prescribing, of course, is that it's local. What about central activity? Child poverty, where child poverty is defined as living in a house at less than 60% median income. Before housing costs, child poverty was 18% in 2010-11. After housing costs, 27%. And that went up to 30%. How was that achieved? These are changes in net household income due to tax and benefit reforms by income. So let's look at working age families with children. For those in the bottom 10% of household income, as a result of the Chancellor's changes to the tax and benefit system, their income would have gone down by 20%. Those in the next poorest decile by 12%, 8%, then the richer you were, the less the reduction. Some reduction at the top, but nowhere near as big as the reduction at the bottom. Government policy was to make poor people poorer. I thought when the Chancellor removed the upgrade to universal credit between Wednesday and Thursday, somewhere in excess of 200,000 more children were thrown into poverty. If he could do that between Wednesday and Thursday, between Thursday and Friday, he could take 500,000 children out of poverty. So central action really matters. The level of child poverty is a political decision made by the Minister of Finance. Local action, we produced Build Back Fairer in Greater Manchester, Health Equity and Dignified Lives. Our strategy looks very much like our 2010 report, Early Years Children and Young People, Housing, Transport and the Environment, Communities and Places, Public Health, Work and Employment, Income, Poverty and Debt, and then Standards, Institutions, Monitoring and Accountability, Extend Evolution, Resources and Future Generations. And as we go forward, what do we need? Government or services? And of course, it's both. If we think during the pandemic, certainly in the first wave of the pandemic, we had the highest excess mortality of any rich country. The US was a disaster in managing the pandemic. We were worse. And I asked myself, how come we had such poor health performance pre-pandemic and had such high excess mortality during the pandemic? So pre-pandemic, to remind you, life expectancy was stalling, inequalities were increasing, and life expectancy for the poorest people was falling. And that slowdown in life expectancy was nearly the slowest of all rich countries. Only the US did worse. And then during the pandemic, in the first phase at least, we had the highest excess mortality. And I think the link between these two is poor governance and political culture, increasing social and economic inequalities, the reduction in spending on public services. We were ill prepared, and we were unhealthy coming into the pandemic. I think we need action on my 6. Give every child the best start in life, education and lifelong learning, fair employment and good work for all, having enough money to live on, healthy and sustainable places and communities, and taking a social determinants approach to prevention. The government is important in that, but so too is what happens locally. When I spent a year as president of the World Medical Association, we produced a report on Doctors for Health Equity, workforce education and training, working with individuals and communities, social prescribing by another name, the health sector as employers, I would now say as anchor institution, working in partnership, social prescribing, and the workforce as advocates. I thought I just turned the sound off. So social prescribing has a key role to play. I can't shut it up. Put it in a drawer. Social prescribing has a key role to play, but we also need this as we go forward to address the poor governance and political culture, to reverse the increasing social and economic inequalities, to reverse, not just to say austerity is over, but to reverse the reduction in spending on public services and to deal with the fact that we're not very healthy. And my overall #1 recommendation is to put a fair distribution of health and well-being at the heart of all government policy. Thank you.
Well, thank you indeed, Michael. That was an absolute barnstorming presentation and a case very well made indeed. And, you know, who cannot feel emotionally challenged by what you've just said. And I suppose, you know, what with the increase in fuel costs and inflation and everything else, you know, this is a situation that will only get worse without action.
Absolutely. And you already hear the spin machine. We knew 15 days ago, before the ghastly events started to unfold in Ukraine, that we had a cost of living crisis with rising fuel bills. And now the spin machine, the government saying, well, it's because of the war in Ukraine that energy prices are going to go up. No, it's not. It's because of other things and the failure of government to deal with the fact that people are getting relatively poorer. And that is government policy. We're a rich country. There's a lot of money sloshing about. Rich people are getting richer. We know that happened during the pandemic. Rich people got richer and poor people got poorer during the pandemic. That happened. It was predictable. The government didn't do much to change it. And the cost of living crisis, a combination of Brexit and other things, and then the war in Ukraine comes on top of that, and the sanctions on Russia. But that's on top of what was already looming. So things are going to get, and it's not just for the poor, it's the gradient, and the inequalities are going to get bigger.
Michael, if you think that government's not listening, what can we all do to change that?
Well, you know, we're being told that the tragedy in Ukraine, I mean, none of us can move without thinking of the tragedy in Ukraine, but we're being told that the tragedy in Ukraine is about democracy versus totalitarianism or whatever. I don't think our democracy is functioning very well in this country, because you say, what can we do to change that? Now, I'm hugely encouraged by what's happening at local level. And social prescribing is one part of that. You notice my fifth of the 5 things that doctors and other healthcare professionals can do was advocacy. And we've been working, I showed you the title of the report, in Greater Manchester, in Cheshire and Merseyside, in Lancashire and Cumbria. We've got a Health Equity Commission. Coventry declared itself a Marmot city. Leeds said, what do we have to do to become a Marmot city? Waltham Forest, Luton Town. We've got local areas all around the country saying, we want to do this. My fond belief, and maybe it's just a fond belief, is if you get the whole country marching off in a certain direction, the politicians will eventually run around the front of the march and pretend they were leading it. We'll finally get them to move. But the rest of us have to be moving in that direction. I mean, this is palpable unfairness that is impacting on the health and the lives of the patients and the populations that we serve. And so my approach to this is, I don't come at this as a champion of, right or left or something else. I come at this as a champion for the health of the patients and the populations that we serve. And I don't want a particular political party. I want a set of policies that will address the reality of people's lives. And we have to be the advocates for that. Now, I'm no politician, so, I had a senior politician of one party I was briefing, saying, we're not getting our message across. What can you advise us? And I said, certain things come with age and experience. And one thing that comes is knowing what I'm not good at. And what I'm certainly not good at is advising politicians at how to communicate. But I can tell you what I do, which is tell the truth, present the evidence, and engage people in a discussion about social justice. Now, that may be foreign to politicians, but tell the truth, present the evidence, and be engaged in a discussion about social justice.
Yeah, well, thanks, Michael, and thanks also for your support and advocacy of social prescribing, of which we're all enthusiasts. But do you feel that maybe my daily work as a family doctor and even the social prescribing is in danger of cushioning the blow of the things that you're talking about, is in danger of becoming an apologist for no action on high?
No, I don't. I would never say we should use human suffering as an instrument to some other purpose. Because in a sense, I know that you don't think that, but in a sense, that's behind your question. Let's not do the good things we could do, because if people suffer more, that might be an instrument to getting political change. Never. Never. That's immoral, and it's against everything we believe in. So, of course, at local level, at the individual practitioner level, at local government level, the voluntary and community sector, we should be doing everything we can do to improve the quality of people's lives and hence their health, everything. But that doesn't let government off the hook. As I said, the idea that the Chancellor, in one stroke, can increase child poverty. And then the rest, I mean, look at the Levelling Up white paper. You didn't ask me to comment on it, but look at the Levelling Up white paper. It's been calculated that in the 10 years since 2010, 11 years, the reduction in per capita spend by local government in the north of the country was somewhere in the order of £430 per person. That was the reduction in annual spend, £430 per person. And the Levelling Up white paper, the current budget, gives £33 per person. Oh, how lovely. Isn't that sweet? Take away 430 and you put 30 back, and you say this is the major government flagship policy for dealing with inequalities. We have to call that out.
Well, thanks, Michael. I was going to ask you about the National Health and Equalities Strategy of NHS England, the Core 25, but I think you've probably answered the question, haven't you?
Well, I think so. I mean, I think Bola Olabi is terrific, and she's, I think, doing a terrific job. One problem with the Core 20+5 is it focuses only on the poorest, on the most deprived and socially excluded. It doesn't deal with the gradient. Yeah.
Michael, this is an international conference. We've got 22 different countries here today. Your message is clearly about England and UK. How do we compare with other countries?
Well, firstly, I mean, that's what I chose to talk about today. Since I did the WHO Commission, we did I led 3 regional commissions in 3 of the WHO regions, in Europe, in the Americas, and in the so-called Eastern Mediterranean region. And the principles were really very similar. We, and over the 12 months since my Build Back Fairer report, December 2020, for the UK, or for England, we produced 3 others: Build Back Fairer in Greater Manchester, Build Back Fairer for the Eastern Mediterranean region of WHO, and Build Back Fairer in Hong Kong. So we think the same principles apply. To come back then to your question, the slowdown in improvement in life expectancy post-2010 in the UK, the slowdown was more marked in the UK than in any other rich country except Iceland and the United States. So forgive me, Iceland, forgetting Iceland for the moment. I ask, what is it about the UK and the US? And the US, they had decline in life expectancy 3 years in a row. We had a slowdown. The US had a decline. It then ticked up a little bit, and then, as we did, a dramatic decline in 2020, both in the US and UK, because we handled the pandemic so poorly. And I think what I was saying about governance and the political culture, the increasing social and economic inequalities, the divestment in investment in public services apply both to the US and the UK. I mean, just take one measure, pre-pandemic, unemployment insurance. If you're unemployed in Denmark, you get 90% of what you were earning. In Italy, it's 80%, in Germany, it's 60 or 50%, and so on. In the UK, universal credit is 14% of median income. If you're unemployed, we're going to punish you. We're really going to punish you. Oh, great. So work is the way out of poverty. The majority of people below the minimum income threshold, i.e. in poverty, the majority of people in the UK in poverty have at least one member of their household in work. Work is not the way out of poverty. We're doing this very badly, and we're doing it worse than most other countries. And the US is with us. For everything we do badly, I look at the US and they do it worse. I mean, take child well-being with adolescents. 38 OECD countries. The UK ranks 27th out of 38 countries on child well-being. The US ranks 36th out of 38 countries. But 27th. It's dreadful. You know, we're below the average. We're sort of, you know, limping along, not the very worst. Whatever I look at, spending on early childhood. Norway spends about $14,000 a year per child, 0 to 5. The US spends $2,000 a year, and we're closer to the US than we are to Norway, below the average. We limp along, we're not the very worst. We're like the England cricket team, you know, we just limp along worse than the average, not doing very well. And then you get a succession of ministers come onto the detailed program saying, we're spending hundreds of pounds on dealing with childhood poverty. And we've got this program of £2 million. Give me a break. So we're doing really badly because we've got out of the business of trying to improve the well-being of our population.
Michael, can I come in and ask you a question here? As the other Michael, I feel like I've got Dixon and Marmot. So as Dixon said, a barnstorming presentation. I think Twitter's probably gone ballistic. We've had quite a few questions come in, and I think a lot of the questions are what can we do, whether it's from local government, from social prescribing. So as we sort of come to a close in this session, I'm thinking, what can the social prescribing community, whether that's commissioners, GPs, allied health professionals, whether that's local government, whether it's link workers, whether it's educationalists, researchers, what direction would you like to point us in? What would be the things that we could do? One thought was, you know, get everywhere a Marmot city. I'm sure we could put pressure on to do that. But what is that practical thing that perhaps we could help you with?
Well, one of the reasons that I'm so excited by the Social Prescribing Network is because for years when I would present, you know, I've updated it obviously, but when I'd present the kind of things that I talked about this morning, and practitioners would throw up their hands and a real cri de coeur say, yeah, but what can we do? This feeling of, oh, we're powerless. You know, you're absolutely right. We see it in our patients day in and day out, that the housing problems, early child development problems, unemployment, so on and so forth. We see it all the time. But what can we do? And social prescribing is an answer, not the only answer, but an answer to that question. What you can do is a great deal. You can work with the big issues that are having an impact on your patients' lives. And that means working in partnership, having link workers and the like. So it's a brilliant answer to that angst-ridden cry of, yes, but what can we do? But it doesn't stop there. We're in the process of setting up a network, interestingly funded by Legal & General, a big financial corporation. And we want, in different parts of the country, to get local government, the voluntary and community sector, ICSs, primary care, other public sector, the police, fire and rescue service, education, and business, all working together, saying, what can we do? And it doesn't, to come back to Michael's earlier question, it does not let national government off the hook. If anything, it exposes the deficiencies in what they're doing. Why have 1,000 Sure Start children's centres closed? Not because individual local authorities said, oh, we can do without these. It's because they were starved of cash. Why have services for adolescents closed? And whether, as a consequence, youth violence rates went up following the social gradient more in deprived areas, not because individual local governments said, oh, we can do without those, is because they were starved of cash. So I think that far from letting government off the hook, getting action, GPs, link workers, social prescribing, and all the other actors I've just mentioned, then should put pressure on national government. Look what they're doing all around the country, and look what you're doing to make things worse.
Thank you. That's brilliant.
Michael, we'll probably have to end there, but thank you for your encouragement. I think that we need that also for your messages, because this is absolutely crucial. And at the beginning of this conference, I believe that social inequalities are exactly the right issue that we need to be looking at. So you've given us fantastic beginning to the conference. I couldn't be more grateful on behalf of everyone. If you looked at the chat section, you would see roses being flung at you and applause from all parts. But the fundamental message is we need action, and we'll carry on our action at the front line, but hopefully we'll start to see some action up at the top, and we can all be agitating for that. But thank you, Michael, and thank you for joining us.
My pleasure. Bye.
So I'm going to take us forwards now, and having heard from Michael Marmot about the real situation when we look at these national statistics and really analyse the situation, we're going to look at some actual referral data at a national data set level, and it's the first time we've been able to do this. Before we do that, I just want to say, Michael Marmot, I will get in contact and I will get information about the Legal & General network that you're setting up so that we can publicise that and work with you, because I know people are already asking how do they get involved. So for everyone that's asking that, we will make sure we do that and put that out through the Social Prescribing Network. So it's my pleasure to introduce two colleagues, Anna and John, who have been working really hard over the last few years with social prescribing and often behind the scenes. But let me just introduce who they are. So Anant is an Oxford Martin Fellow at the Oxford Martin School at the University of Oxford. Currently works on understanding how we can improve population health through social prescriptions and by addressing social determinants of health. And prior to his position at the University of Oxford, Anant worked in Europe and the Middle East to help healthcare systems within these countries focus on value-based healthcare. And Anant's PhD is in immunology from Yale, so you are a well-travelled scholar, Anant. And welcome to John McGuinness as well. So, John, you're a GP, you're an RCGP clinical champion for social prescribing as well. And your recent work's been supporting the development of there's a lot of acronyms here, the RCGP, RSC, Social Prescribing Observatory with the PRSB. Now, I could give you all of those, but I'll let you all explain that. You're a GP clinical lead for developing social prescribing information standards as well. So I'm going to hand over to you to give us an idea of what's happening with determinants of health and social prescribing referrals.
Can you hear us?
I can hear you, and I think John's on mute at the moment, so.
Yes, we're muted. Yep, good to go, Alan. Over to you. Okay, thanks. Thanks very much, Marie. Really great to be here, and tough act to follow, following Michael Marmot, but we'll try. So, likes to pop up. I don't see them yet. I don't know, John, do you see them, or Marie?
Yes, we see your slides.
Ah, okay, yep, I see them now. Right, so as Marie said, we have been working with Simon de Lusignan's group at the University of Oxford. Simon is director of something called the RCGP-RSC, which is one of the acronyms that Marie mentioned. And RSC stands for the Research and Surveillance Center. It's a sentinel network that was set up about 60 years ago of GP practices dotted across England, which are nationally representative. Data is extracted from the EHRs from these GP practices twice a week. It's pseudonymized, and then it's made available for surveillance and public good purposes, like this project. So that data set was also used for monitoring COVID. It was used for monitoring swine flu, and there's about 1,800 GP practices. And what we'll be talking about today is a report that John and colleagues and I worked on that was published in August 2021, which looked at health inequalities and the use of personalized care in England from April 2017 to March 2021. One other thing to say is that on the bottom right, you can see a link, and all of the data, some of the raw data and the reports are available there. Next slide, please. So what we have here is an overview of some of the data that we extracted on 3 broad domains: social need, personalized care, and the use of non-medical interventions. Next slide. And delving a little bit deeper into this, for social need, we used primary care codes derived from SNOMED CT to identify individuals presenting to primary care with issues like mental health concerns, non-severe mental health concerns, long-term conditions, substance misuse, abuse, employment issues, parenting issues, money issues, and housing issues. People would have presented, and if the GP coded this, then it would have popped up on in our analysis. And basically what we found, this analysis is looking from 2020 to 2021. We found that there are about 15 million instances of people presenting with social needs that could have benefited from a social prescription in the 2020-2021 financial year. Next slide. And then next, what we wanted to look at was to see what was the use of personalized care interventions as well as non-medical interventions for this financial year. And what we find is that there was about 1.2 million instances of some form of personalized care being taken up, over 1 million of which were social prescriptions. And there were about 3.2 million non-medical interventions given, so with physical activity referrals being the dominant modality of intervention. The upshot of these numbers, if we add up 1.2 and 3.2, is we get about 4.4 million. And if you remember the previous slide, there was about 15 million instances of social need. So the bottom line for these 2 slides is that there's I think it would be safe to say gross underuse of these types of interventions for people presenting to primary care. Now, of course, it could be a coding issue, so it could be that the quality of coding is not good, and GPs are referring these individuals, but they've just not coded it. It also could be that these individuals are finding help elsewhere. But based on what we found in the recorded data sets, there's gross underuse of these types of interventions to support people with their social needs. Next slide. And we also find quite significant variation across multiple domains. So if we look at the different ICSs, and you can see the heat map on the right, we find that there's up to 25-fold variation between ICSs in England in the use of social prescribing. So the darker colored ICSs use more, the lighter colored use less. For sex, we find that women had 1.5 times higher social prescribing referrals compared to men. For age, we find that there's 2 times higher referrals for the 65 plus demographic compared to any of the other age groups. And the referrals for children, kind of reflecting on one of the opening talks, was extremely low. Children are basically, not presenting to primary care with their concerns, and it's definitely something that we need to be paying attention to. So the bottom line from the general analyses, social prescribing use is growing, but it's uneven across England and population groups. And I think it's safe to say that there's an underuse of these different types of interventions. And with the next slide, I'll hand over to John to talk about inequalities and what we can do from a primary care perspective to try to tackle some of these issues.
Thank you. And so just to start off with social prescribing and health inequalities. Sorry, I've got some sticky keys here, keeps advancing. So the diagram on the left here will be a familiar message to lots of people on the conference today, that health and well-being is not just about healthcare or clinical care, the work I do as a GP, but it's about the environment which we live and work in. And I think that's why social prescribing is so important, because it's really getting to those health behaviours, those social economic factors to really make a difference. We've heard from Michael Marmot about the 6 Marmot principles there, and that's exactly where we should be focusing. On the right here, we've got the NHS's approach to addressing health inequalities at an integrated care system level. And as we heard, it's not perfect, but I think it's a really good place to start, focusing on those in our population with the most need. And also there's some localization there, so focusing on the integrated care systems, targeted populations, as well as 5 key health domains. Let's delve into a bit more of the data on ethnicity and deprivation, and thinking about social prescribing referrals. So we've got 2 graphs here. So on the left, it's a bar chart, and that shows the quintiles of index to multiple deprivation. And these are rates of social prescribing referrals per 10,000 population over the last financial year, so 2020 to 21, so within the pandemic. And what we can see is that in the most deprived areas or neighbourhoods, social prescribing referrals were higher than less deprived areas. What we also see in the data, which is in the background, is that there is higher rates of declines for social prescribing referrals. And so the worry is that suggests that the actual uptake of social prescribing in these areas is lower. And I do believe that social prescribing should follow the social gradient, which Michael Marmot so clearly lined out. So we need to ask the question of, are we reaching the right people? Sorry. And if people are declining, why is that the case? So the graph on the right here, looking at ethnicity. So you can see there in the bar charts, this is a rate per 10,000 population again. And non-white ethnicity backgrounds that had significantly lower referrals to social prescribing schemes. We also highlight that there is gaps in ethnicity data in primary care records, which is well known, and looking at the other and the unknown. So again, thinking about how can we really ensure that we close these gaps so that everyone has access to social prescribing, and we need to ask the question of, are our services ethically and culturally appropriate? So We know that people are recording social prescribing referrals. We also know that there's some actually really good data out there by social prescribing services, but we also know that there is underreporting of using the social prescribing referral codes, and the data quality can vary significantly. So over the past 9 months, the NHS and PRSB, Professional Record Standard Body, have been developing an information standard. And what this is it builds on top of a minimum data set for social prescribing, which looks at coded data in electronic health records around social prescribing. And the purpose of this standard is to really ensure that we're all speaking the same language when it comes to data and recording information around social prescribing. We really believe that it will support everyone who's part of the social prescribing journey, from the service user, the referrer, link worker, and the GPs. And it will also support us in showing really the impact and evaluating social prescribing nationally and locally. And in terms of, this is what the data journey will look like, and you can see here that there's some key information picked up around on the referral, which we know is important. And then say when you move to the next column, so conversation with meet the link worker, this is when we pick up some of those information around personalised care, so ensuring needs, strengths, goals and actions are recorded in a standardised way. And as we move through the journey, you get to the end where you get a message back to the GP, which we know is so important. And I'm really pleased to say that it's going to be launched in spring 22, so watch this space. And also to say that we've developed this with input from VCSE organisations, from focus groups, from experts, from people with lived experience of social prescribing. And we believe that the information standard will work for not only the link workers in the NHS, but everyone who's part of the social prescribing environment. So a really exciting development. So Ananta and I have just highlighted some of the evidence around social prescribing referrals, particularly looking at the variation in England over the past financial year. And it's really important that, as Marie said at the start, that we all support building this evidence bank on social prescribing and its impact. We really would encourage people to look at the variation at a local level and at an integrated care system level on who is accessing social prescribing. Moving on to inequalities and unmet need. I mean, a fantastic presentation from Michael Marmot, and he uses the phrase proportionate universalism. So social prescribing needs to be for everyone, but it also needs to match resource to that gradient. So those of them who have the most need to have the most resources. This needs to be done with local input from the community. So really listen to your community, think about what they're saying to you, and then with those information you can target the social prescribing. And I do think the core 20+5 will help and support people to do this. We've talked a bit about quality, about how can we improve the data quality around social prescribing, and as I said, the information standard will be launched in spring 22. And it's all about learning together, which is why it's so exciting to come together at this conference and share this small bit of presentation for you. But we really believe that it's about identifying and spreading best practice. We're well aware that data is only one part of the solution, and we need to use the human skills, the relationships, and build with local expertise and knowledge. So thank you all, and I'll hand back to Marie. I'm really looking forward to hearing presentations through the day. Thanks a lot.
Thank you so much, John and Anant, for really putting together a very concise account of what I know is a huge amount of data that you have at your hands. Just to say that the whole conference is being recorded, so if you've been asking about getting slide sets, we will have presentations available, and this will be recorded and you'll be able to access it again. So we're running a little bit behind because we had a technical hitch to begin with, but I want to just ask one specific question, Anant and John, which has come in. I think there's people just wondering if they're not using SNOMED to record data, and how do we go forwards if we're not on SNOMED? Like social prescribers at AGK, someone's put, would not use this either. So how can we collate all this national data more effectively? So I don't know if you just want to come back to us on that one.
Yeah, maybe just to start. I mean, as the information standard has been developed for social prescribing, we've had input from people who use electronic health systems, which may use a SNOMED code typically, but also from people outside Age UK and local authority. And the hope is that by speaking the same language and recording the same thing, whether that's coded data or not, it means that the transfer of data is more simpler and people really understand what is being putting down. So that's what we're looking to do with the information standard. So we're not purely limited to that SNOMED coding.
One comment that I would sort of follow up that I would make to that, and kind of riffing off of something that Michael Marmot mentioned. I think one of the most important things, data is a means to an end. It's not an end in itself. The data for local areas are collecting data in their own way. I think it's great, and I think it's important that data be collected nationally, but I think it's important to recognize that it's a minimum data set, and it's not going to capture everything. And so if local areas can actually start capturing some of that more granular information, and then using that to create feedback loops within their system that continuously improve, that's extremely powerful at a local level. And it can also provide examples of what can be done at a national level. And that can be done with SNOMED, without SNOMED, it can be done in Excel, spreadsheets, it can be done with paper notes. But the key thing is that that data is used to create feedback loops that generates these continuous improvement cycles. And that is something that's oftentimes lacking in very data-rich systems and data-poor systems as well.
Oh, we've just had a slide go up, so I don't know if Andre can just remove that slide for a sec. But we are still talking. Thanks, Andre. I think that's really important about the feedback loops, and I think it's really important about what's happened, Andre.
It's not up.
Oh, okay, thanks. It's really important about having the feedback loops to understand what's happening in local area. We can see there's a lot of variation across the country. We've had more questions come in, and I'm publishing them. And I just wondered, Anant and John, if you're able to respond to some of the questions in the Q&A thing, because we need to go to a break now. I really look forward to seeing how this approach to now being more strategic about collecting the social prescribing referral data and the outcomes, moves forward. There's a huge amount of work you've done. Thank you very much. And perhaps I can invite you to write a blog for the Social Prescribing Network on this as well, and tease out some of those difficult questions for the voluntary sector of how do they get on board and how is it going to work across all sectors. So thank you very much. Appreciate your time. So we're running a few minutes behind. We're going to take a break now. We're going to take a break for about, I think, if we say 8 minutes, that's a quick chance to move around, get the kettle on, and we'll start at 10:49 with our next session. So thanks very much, everybody.
Thanks, Marie.
I'm not sure if we're still there.
Can you hear me, Marie?
I can't.
Hi, Andre, can you hear me? Can you hear me? Can you hear me?
Yeah, off you go, Janet.
Hi. Are we ready to start?
Well, I think we are, so I'm handing over to you, Janet.
Excellent. Good morning, everybody. Very warm welcome to this session, which is on how social prescribing schemes are addressing inequalities, which is a particular interest of mine, and it's examples from the field, so very practically focused. My name is Janet Veach. I'm the chair of the UK Women's Budget Group, and we undertake analysis, economic analysis from an equalities point of view, particularly differences between men and women. And it's my pleasure this morning to be co-chairing the session with Dr. Polley, who everyone knows, but is the co-chair and co-founder of the Social Prescribing Network. I'm going to ask everyone to mute themselves while they're not talking. We've got 3 fabulous presentations, and this will help minimize any background noise, which I'm very familiar with on Zoom because I've got 2 noisy dogs. Just a reminder to people that the chat box, which I know you've been using this morning, chat box is open for questions as you think of them. We're going to take questions at the end of each presentation, and then again we've got a space at the very end for discussion. And we obviously want the conference to be as interactive as possible. It's always difficult doing these things by Zoom, but please do give us your reflections, use the chat box, and we'll take questions, but we'll also take comments, general reflections, any thoughts you have. So let me start off by introducing our great panel this morning. We're going to hear from Anna Barnish, who is the, as you know, the Health and Development Manager for Citizens Advice in the Wirral, and from Laura Arrowsmith from Maternity Action. And they're going to talk about their health justice partnership, some of which I was intrigued to see is actually based in the hospital I was born in many years ago, Victoria Hospital in Wallasey. And then we're going to hear from Damon Gibbons from the Centre for Responsible Credit. Interesting ideas about the link between long-term health conditions and debt and how important that is. And he's going to talk particularly about a project in London, Lambeth and Southwark, and what they've done there. And finally, we'll finish with Sarah McLaughlin, who's going to talk about her work with older people in Northern Ireland. Sarah's from the Mid and East Antrim Age-Well Partnership. And we've got some very interesting calculations on the return on investment for that work, which is something we all need to think about. So today our panelists have 8 minutes each. I'm going to be very strict with time in order to give us time to have a proper discussion. So I'll warn you when you're at the end of your 8 minutes and you need to start wrapping up. And I've called the presentations fabulous, partly because I've read them, but mainly because they're exactly what I want when I go to a conference, because they're talking about concrete realities, the practicalities, how social prescribing is actually working, what are the pitfalls we have to think about, what are the successes. You'll be able to ask questions of experts who are actually doing the job, maybe compare it with what you're doing at the moment, maybe think about what you might do in the future. Okay, so that's enough from me. Anna, Laura, the floor is yours.
Thank you so much for the opportunity to speak today. If you'll just bear with me a second while I share some slides with you. So hopefully you can all see them and hear me okay?
Yeah, they've come up, yeah.
Fantastic. So yeah, thank you so much. It's great to be here. So I'm Laura Arrowsmith. I'm a senior policy officer at the charity Maternity Action, and I'm just going to very briefly tell you about our health justice partnership work. So for those of you who may not know Maternity Action, we're a maternity rights charity dedicated to promoting, protecting and enhancing the rights of all pregnant women, new mothers and their families to employment, social security and healthcare. We run a number of specialist advice services and we also undertake policy and campaigning work. So today I'm just going to focus on our maternity rights advice service as that's the most relevant to this particular project, but we do also run services that support vulnerable migrant women too. So our maternity rights advice service delivers telephone and email advice on a range of issues, including maternity rights at work, maternity pay and benefits and breastfeeding rights. The service is staffed by our team of in-house employment lawyers who all have expert knowledge of maternity rights at work and maternity benefits. And the service delivers high quality specialist legal advice and is often oversubscribed, so we know that there are more women in need of support and advice on the issues that we work on. So our project has been about integrating the advice from our maternity rights advice service into maternity services using the model of a health justice partnership, which are collaborations that embed legal support into healthcare services and teams. So the model is very much about providing non-clinical support in a healthcare setting, in this case through establishing a direct partnership with a health service. So in this instance, we're not using a social prescribing link worker model. Health justice partnerships aim to increase access to legal advice and support by situating services or referral in locations where we know people are already likely to present with an underlying legal advice need that might be affecting their mental or physical health. And we know that there's evidence that these models have the potential to save practitioner time through providing a referral route for when non-clinical questions are raised. And by providing specialist advice and support, they aim to equip service users with practical tools to address challenges in areas that are the wider determinants of health that we know underpin health inequalities, so in this case income and employment. So we've been working with the Cheshire and Merseyside Women's Health and Maternity Programme, and we're really excited to be starting a pilot project in the Wirral next month, which will establish a maternity health justice partnership with the maternity service at the Wirral University Teaching Hospital NHS Trust. So this will provide a dedicated maternity rights advice service for women and families using the maternity service, which will enable midwives to refer directly to maternity action when women raise questions around employment, maternity pay and benefits. We know that maternity services are very stretched at the moment, so one of the aspects that we'll be looking to evaluate is the potential time saving for midwifery teams from having this service in place. We've previously done a small survey of callers to our service, and we found that around 30% of them have already spoken to a health professional about the issue they were contacting maternity action about, most commonly their midwife. So we know from speaking both to women contacting the service and from speaking directly to midwives that these questions are being raised in maternity services. And we'll be looking to embed the service and develop connections with other local agencies that are already in place to be able to connect women on to other agencies and services where they may have additional needs that we're not able to support with directly, such as the work done by Citizens Advice Wirral. So for women using the maternity service, it will provide easier access to specialist legal advice on maternity rights. We know that unfortunately poor treatment of pregnant women at work is widespread, and there's evidence to suggest that that has worsened during the pandemic. And our service makes a real difference to women's lives on these issues. So we know from our evaluation work that our service helps women to retain their jobs, reduce stress, resolve problems at work, as well as accessing maternity pay and benefits. Pregnancy is a time where employment and income circumstances are often changing, and so the service will provide practical support with issues that we know impact on health and health inequalities. Over to Anna, thank you.
Thanks very much, Laura, and I'm going to continue with the theme of partnership in explaining how Citizens Advice Wirral is looking to address health inequalities through the development of a social prescribing hub at Victoria Central Hospital. We've already heard from Sir Michael Marmot this morning, who outlined how patients seen in clinical settings may well have problems in their everyday lives that may be causing or exacerbating their mental and physical ill health, or may be getting in the way of their recovery. And so it's for this reason that we were delighted to be approached by NHS Property Services over a year ago to explore some of the vacant non-clinical space at Victoria Central Hospital. And this space in Wallasey houses primary, secondary and community healthcare services. So it's a fantastic opportunity for really embedding social prescribing in healthcare. So this soon to open hub, to be called Flourish Wellbeing Hub, will bring to Wallasey, an area devoid of specialist services, the opportunity to access social welfare, mental health, drugs and alcohol, domestic abuse and dementia services. All services that we've already heard this morning are paramount in improving people's health and well-being. Just to put some context into Wallasey, over a quarter of children live in poverty, a third claim housing benefit. The rate of residents claiming ESA for mental health reasons is the second highest in the borough, and death caused by alcohol is almost double the national average. So again, it really epitomises how social prescribing in an area of deprivation is so important. So this hub will ensure that patients tell their story once. It's a big ask, but that's our aspiration. We understand what matters to the patient. We listen, a key pillar of personalised health. And through the development of a data collection app, we hope that we are able to ensure that someone tells their story once. A seamless transition pathway is therefore provided from one service to another. We also hope through this demonstration, through this data collection app, that we'll be able to demonstrate to partners how the delivery in healthcare settings results in the best outcomes for individuals, reducing that revolving door that we know so many patients experience. We hope to be on site later this month once the refurbishment are completed, and we're delighted to have been working with the Ministry of Justice to demonstrate impact and share best practice, reaching and supporting our most vulnerable. Being in a healthcare site, the training of and partnership with our healthcare professionals, as Laura has already mentioned, is paramount to making this work. As an organisation, we already host first and second year nurses and train our GPs as future healthcare workers, but the success of this site depends on that partnership being embedded and enhanced. We'll be taking stakeholders with us on our journey. The cafe, which will be the focal point of our service delivery, for instance, will be open to all, making sure that even our population of healthcare workers on site are able to find something healthy to eat at lunch and have a breakout space where people will be able to interact. Next slide, please, Laura. Citizens Advice Wirral has been delivering social prescribing services since 2018, when we were funded for a small pilot by the Department of Health and Social Care working with Age UK, targeting those with chronic respiratory conditions. Through our learning, we were able to take our conversations forward with 5 of our 7 primary care areas, and also to expand into secondary mental health and our specialist COVID clinic. We made sure there was an easy referral route for partners to ensure that patients identified clinicians were able to be signposted. We've also been able to impact significantly on those that may be experiencing health inequalities and explore some work enabling those who were unable to access universal healthcare, for example SMEAR, and remove some of those barriers. We undertook a very successful piece of work in one primary care network area, which resulted in a 57% increase in the SMEAR uptake amongst women over 40 who'd never been for a SMEAR. Like we've already heard this morning.
Anna, can I just let you know that the time is tight? If you could wrap us up, that would be great. Thank
absolutely.
You.
We move on to the next slide, Laura. I'll just highlight some of the work we've been doing, particularly in one primary care network area, Moreton and Mells, where they've invested in exploring health inequalities. And through this lens, we've been able to look at the impact of a fibromyalgia diagnosis and work for the development of an EMIS template to ensure a consistent approach to diagnosis and support. Just to wrap up then with Citizens Advice Wirral, next slide please, Laura. We've been providing impartial, confidential advice to residents since 1939, and we pride ourselves in the way that we work in partnership, understanding and addressing some of those inequalities that disproportionately affect individuals. We know our support makes a difference. We know that people's mental health and physical health is impacted by benefits, for example, and we know that we can continue to champion that as our service progresses. The slides will be available and I'm here for any questions, although I can't see the chat, unfortunately, so happy to take questions. Thank you.
Thank you very much, Anna and Laura. That was really brilliant. And I'm really sorry to be tight for on the time, but you know how things are. So let's have a quick look at questions. Marie, do we have any questions at the moment for Anna and Laura?
Take myself off mute again. I'm terrible this morning. Right, so there were a couple of questions. One person asked, how did Citizens Advice obtain funding for the project at VCH? That's the Victoria Hospital, isn't it?
We've been working in partnership with the Property Services team, who have been looking to provide some investment in social prescribing in those clinical settings where there was vacant space. And we were lucky enough to be approached by the Ministry of Justice to be able to demonstrate how health justice partnership work makes a significant difference on health inequality.
So that was a real partnership working, conversations, trying to plug into the right areas to leverage that funding. So that's great. There was one other question. Now, this came in quite near the beginning of the presentation before we started talking about the Social Prescribing Hub, but it said the Health Justice Partnership model seems to be very effective. It reduces the number of links people have to go through for the advice they need. Is it in conflict with the Social Prescribing model?
I'd be happy to answer that if that's okay.
Yeah.
So I mean, I think for us it's very much complementary to social prescribing. So I think, you know, the idea of the Health Justice Partnership model is that it's very much about providing that non-clinical support in a healthcare setting. It uses a slightly different model in that it's about integration, and you know, I think for us that's the model that we've been working to. But I think, you know, from our perspective, you know, we're providing a service that addresses the wider determinants of health, and I think there's just an opportunity really to consider those broader models beyond the link worker setup. I think that's how we view it, that it's not, we certainly don't see it as being in conflict, but just another tool and another sort of way of integrating services that can support people in a way that can complement social prescribing schemes.
Thank you. That was all the questions. So Janet, back over to you.
Thank you, Marie, and thank you to the people who put those questions. Really interesting points. So let's now go, if you're ready, Damon, to Damon Gibbons from the Centre for Responsible Credit. Damon, the floor is yours.
Well, thank you very much, Janet, and it's a delight to be here, I have to say. Fantastic presentations already this morning, and I'm learning an awful lot. You might ask yourself, what is the Centre for Responsible Credit doing at a social prescribing conference? Well, we're here to talk about obviously the links between debt and health, which run two ways. All the evidence indicates, you know, clearly financial problems create health problems, and health problems can create or exacerbate financial problems. So there's a clear link in all the evidence. I'm just going to get some slides up and just run you through those once I can find them. There we go. Okay, so I'm here to talk about a specific project that we're leading on in parts of Lambeth and Southwark, and it's called Financial Shield. It was conceived at the time of the COVID pandemic, hence the shield aspect to that, but we were concerned about shielding people not just from the virus, but from the financial impacts of that. But it goes beyond, obviously, health inequalities, as Sir Michael Marmot and others have pointed out, have a long history. They're not simply a problem caused by the pandemic. So it's extending beyond the pandemic itself. And we're trialling it in parts of Lambeth and Southwark. It's not across the entire two boroughs. We're in Stockwell in Lambeth, and we're in Peckham and South Bermondsey in Southwark at the moment. It's funded by a charity, Impact on Urban Health, formerly known as Guy's and St Thomas's Charity. They rebranded recently, and it's with a delivery lead for it, which means we take the coordination approach on this, bringing multiple partners together. And as we'll come on to later, that includes advice agencies, primary care, GP practices, and also creditor agencies. Okay, so just briefly, what are the pilot objectives? Well, to improve both health and financial well-being outcomes. We're focused on working age residents with or at risk, actually, of long-term health conditions, and we'll also work with people who are living with residents who are outside of working age, but perhaps have recurring responsibilities as well. We're particularly focused on bringing creditors, health and community pathways together in a proactive way to identify people who are likely to have both debt or other wider financial problems and health problems, and bring them into support in a joined up way. And as part of that joining up, we're looking within the creditors, and we're particularly talking here about the two local authorities, Lambeth and Southwark councils, and at the moment 4 housing associations that we've got working with us, a new joint debt recovery protocol. So where we identify residents who have got debts, there is a hold put on any rent and council tax collection, and if, for example, they're a housing association resident with rent arrears and they've also got council tax arrears, then those two creditors will work together rather than compete for what little money may be available towards payment of those arrears. So we're trying to embody a new joint debt recovery protocol as part of the project as well. And of course, there's an independent evaluation to consider the business case moving forwards and what a funding model might look like. So we know clearly within the NHS long-term plan, there is money for social prescribing. Can we bring in additional money from some of the creditor organisations which could boost that and add specialist roles, particularly around benefits advice and debt advice into that system? So as I say, we've got creditors, health and advice agencies working together. How does that work in practice? Well, firstly, the creditors share information about their arrears patterns and identify postcodes where there are concentrations of debt. Those postcodes are then passed to GP practices who search their patient list for working age individuals with or at risk of long-term health conditions. And the GP practices text message those patients, alerting them to what we're calling, from a resident-facing perspective, we don't call it Financial Shield, we call it Back on Track. So alerting them to the new Back on Track service. Creditors can also directly text residents that they've identified from their own lists as potentially having health problems and arrears. And we take referrals from social prescribing teams and GPs as well. There's two ways residents can currently onboard. The first is through the getmebackontrack.org.uk website, which we've built, which just checks that they are registered with a participating GP. It asks whether or not they're a particular housing association tenant, although they don't have to be, and it asks a little bit more detail about the financial and health problems that they're having, and they can book an appointment or request an appointment directly through that website. When they do that, it will immediately inform any creditor agencies that are participating that they have entered the scheme, and a hold will be put on any debt recovery action for them at that time. And they can also express whether they want a face-to-face appointment or need a phone call appointment as well. So things of that nature through the website. We do also have a paper-based system. We're aware that many of the residents we're talking about are digitally excluded, and therefore we've introduced a paper-based leaflet system which allows them to sign a consent form for the data sharing back through a free post envelope service as well. So those are the two main mechanisms. We've got 6 financial support link workers that they're actually directed to. 2 of those are based in Age UK Lambeth, which also hosts the social prescribing team for Lambeth. So they're pretty much embedded within the social prescribing setup within Lambeth. 4 of them are in Citizens Advice Southwark. And that came about primarily because we were looking to originally embed the financial support link workers in the social prescribing teams within Southwark, but could not recruit to those specialist roles. And so instead, we've set up a subcontracting arrangement with Citizens Advice Southwark in that area. As I've said, creditors are notified and there's a 60-day hold on enforcement. And then we work with people, those link workers work with people to maximise income, but also critically to discuss the issues around health with the existing social prescribing team so that they get both financial support interventions, including debt advice, and also other interventions that may be available through the social prescribing team, and keep creditors informed about progress. So this is pretty much some of the branding and some of the illustrations we use on the customer facing or resident facing aspects of the project. As I say, it's back on track, gives you time and space, sorts out your money, gets you better support for better health, and keeps you back on track is pretty much how we do that. Coordinating the arrears recovery, these are the creditors that are involved. We've got a joint creditor forum now with these 6 creditors brought together within it, as you can see there. And as I've mentioned, they do now all sign up to a joint debt recovery protocol if there's more than one debt outstanding with each of them. I'm just going to put to some quick learning points. So firstly, it's not easy. We've got 3 different primary care networks, 2 different advice agencies and 6 creditors to coordinate across 2 different boroughs. And of course, you know, trying to create a project at the time of a national pandemic as well in primary care services hasn't been straightforward. We have faced a number of challenges around that, particularly around the data sharing agreements, getting express consent for data sharing from residents, and all of the common monitoring processes that we've needed to embed within the project to hopefully help us make a business case moving forwards. That's not been straightforward, let's be frank about that. But we have had over 500 cases so far, and the routing through GEP practices and social prescribing teams is working, by which I mean that it is identifying people who have not already been receiving financial support, but who do clearly need it. So we're very positive about the results of the proactive approach that we're taking to target residents. And clearly residents, and it will unfortunately only get worse, have very complex problems. The benefit system, because it's means tested or targeted in the ways that Michael was talking about earlier, is complicated. It can take considerable time to resolve, and we've reduced an initial target that we had of 2,000 by the end of this year accordingly, because quite simply people need time to be worked with. And I think Daz's point actually gave the terrific evidence about the importance of social prescribing earlier, shows that it is a journey and people do need to be picked up at different points. It doesn't necessarily proceed in a smooth and straightforward direction, but we know we're making a real difference.
Can I just alert you to time passing, if you could stop?
You can.
Thank you.
I'm coming to the end, Janet, don't worry. We do know we're making a real difference. There's a case here, I won't go through it because the presentations are available, but you can see the sorts of case studies that we're dealing with, and we do know that depression and anxiety is a particular issue within the project, and mental health services and issues are clearly apparent. You can join our own network. There's a link there within the presentation, so please do so. Let's move to questions.
Thank you very much. That was fascinating. Marie, do we have any more questions at this point?
Muted, Marie.
I think you're still muted, Marie.
I think I've learned by now. We haven't had any questions in for Damien yet. People can still put them in, but we haven't had any from the audience. I didn't know if you've got any questions, Janet.
Well, I'm always interested to know what kind of the key takeaway was, and Damon, you kind of addressed that really clearly. But this question of debt, obviously, Women's Budget Group, we're very interested in the whole economic model. What would you say is the main thing that you've discovered from your project that you think needs to be done? Where could we make the most impact most quickly?
Well, I think it is the joint approach that people have debt problems and financial problems, sure, but it does interact with their health. And unless we're addressing both sides of that, then actually, you know, we're missing quite an important thing. So I think this is the first occasion where, you know, we're trying to definitely link up social prescribing and the wider activities around health, non-clinical interventions around health, but with the financial support as well. And I think fundamentally, one of the really critical things about this project is whether it can prove the business case for creditors. Will it mean that rent and council tax collection is improved as well? And does that create a business case for them to put money into the expansion of this sort of model alongside what the NHS can put in around social prescribing? So we'll see how that pans out. But fundamentally, we know we need to massively expand support for people in deprived areas around both of these issues. We know that budgets are already stretched, and we've got to prove a business case for that. And that's what we're trying to do.
Yes, thank you very much. That's always the holy grail, isn't it? Trying to make the business case for why you should invest in something. And that brings us nicely to Sarah. Sarah McLaughlin's presentation, which I noticed adds some information about the return on investment from what you've done. So welcome, Sarah. Like our other speakers, you also have 8 minutes. So please go ahead.
Thank you so much for inviting me along this morning. It's very, very interesting presentation so far. Just going to share some of my slides. So everybody seeing that okay? Yes?
Yeah, they're through okay.
Perfect, thank you so much. So my name is Sarah McLaughlin and I'm the Impact Age Well team leader at Mid and East Centre Age Well Partnership here in Northern Ireland. Mid and East Centre Age Well Partnership is an older person's charity. We were set up in 2011 and our mission essentially is to help older people actively age well, here to listen to them, to share experiences with them, to explore challenges that they have and pursue opportunities to improve all of their health and well-being. We felt strongly that there needed to be a shift left really to ensure that older people had a population health approach to their care, and that could be achieved, and that older people would be considered as partners in their health and care. We wanted to go beyond dealing with the ill health and start to look at health in a more holistic way for people and talk to them about health creation and preventative measures. Impact stands for involving many to prescribe alternative care together. So in 2015, the Dunhill Medical Trust launched a funding opportunity to develop a network of care for older people at a local level. And we knew this was our opportunity to talk about not only talk about co-production, but to challenge our statutory agencies to work alongside us in the community and voluntary sector, to put principles into practice and to put social needs on a par with medical needs. So we secured an investment of £1 million in 2016 through the Impact Age Well multidisciplinary model of care over a 3-year period. And that was to work with people aged over the age of 60, living with one long-term health condition or frailty. And then this was followed by a 5-year plan in March 2020 in conjunction with the Dunhill Medical Trust and our Health and Social Care Board here in Northern Ireland. We set up Impact Age Well locality hubs across our region, and that was essentially to have the priority of building face-to-face opportunities to engage all health and social care sectors, from community pharmacy, general practice, secondary care social workers and the community and voluntary sector to sit around the table together, and we offered all partners resources to protect their time. So essentially, once identified, the Impact Age Well officer attends the older person's home over a period of 6 months to look at what matters most to them and to help them to take the lead in planning their health and well-being. The hub can then continues to receive feedback on the progress from the officer, and then the hub helps to close the gaps in terms of health and social care the older person may need in order to stay happy and healthy living in their home. We've slowly but surely expanded over the last 5 years, having finished our most recent quarter supporting 19 GP hubs on a bi-monthly basis and having received over 1,900 referrals. So we're going to now have a quick look at a video which essentially shows how it works in action.
My name
Don't hear the video there, sorry.
I'm not sure whether we're going to be able to get sound. We are. I'm getting some information from just watching it.
Apologies there.
But is that okay?
Yeah, no, that's fine. It will be available, as you say, on the slide. So we'll switch on. Maybe I haven't shared the audio there for that, so that's disappointing. But anyway, we'll carry on. So essentially the video shows how the project works in action, and health inequalities are at the heart of our project and how it's designed. And health inequalities in later life reflect the cumulative social disadvantage over the person's life course, which is why that person-centred approach that we take is vital in incorporating social prescribing. So over the course of the 6-month visits, we navigate the older person through their support with the help of the My Impact Age Well plan. So they receive that at the first visit. And we look at the 5 social determinants of health through the topics my home, my well-being, my community, my future, and my health. These topics which encompass the social, economic and environmental factors that Michael talked about earlier that affect the individual's health and quality of life. So that in the video would show as could be a referral to benefit debt advice, as we spoke about earlier, to the crime prevention officer for a check on the security in their home, or could be an organisation to support their long-term health condition. Our initial visits really just expose the tip of the iceberg that's invisible to the GP in their 10-minute consultations. We previously had a service user refer to the project by her GP who was having a lot of trouble sleeping at night, and she didn't want to take sleeping pills. At the first visit, the officer noticed that the lady's front door wasn't closing properly and was very run down. During the visit, the lady had disclosed that she wasn't very well off and she budgeted very carefully. At the second visit, the office mentioned the door again when she came into the house, and the lady said it was causing her a lot of anxiety because she couldn't afford to fix it, essentially, and because of that she wasn't sleeping well at night. So we were able then to refer her to our subsidised handyman service who works in partnership with us. And Vincent was able to take the door off, fix it and paint it to make it as good as new. And this eventually helped her sleep problems and was life-changing for that lady. So this is a deeper look at the My Impact Age Well plan. This is my community. We try to look at the barriers and the opportunities for the older people, what helps them to age well and what stands in their way, and how we can work with the person to put referrals in place and connections which will reduce their health inequalities in these areas. Each topic is helpfully illustrated with a case study so the older person can relate to that and see examples of where we've been able to help someone in a similar position to them. So we also look at the needs of our older person whenever we are recording the actions that we take part in. So these are recorded under the health headings again, and we hope to continually survey and assess the needs of our older population through recording these actions. So we can see from the results we've had so far that my well-being is at the top of the actions we've carried out recently, and we can't underestimate the effect of the pandemic that's had on our older population. You know, it's affected everyone from the early 60s demographic right up to the late 90s. And we essentially have a generation of older people in their early 60s who are really afraid to leave their home, and that is going to affect that generation going forward in later life. We also have a dearth of community groups here in Northern Ireland who are afraid to start up again. We've lost a lot of older volunteers, and that will generally affect our social prescribing and our connection back into the community. In our Share the Learning report back, it was first done in 2020. So that was a 3-year action research evaluation of the first 3 years of the project. We were determined basically from the outset to ensure that we had an opportunity to build robust evidence, and we were supported by the Social Care Institute for Excellence to complete this evaluation over the first 3 years. So we wanted to look at how the evidence through the fiscal return on investment, i.e. how much could be saved in terms of unscheduled health and social care visits by the project, through the social return on investment, i.e. we looked at the impact and the outcomes of the project on service users, their carers, the healthcare practitioners who took part and community partners. And also then our community pharmacy partners who take part in the project conducted their own separate evaluation into the effectiveness of their involvement in the project. And I think you'll agree the results are very impressive. We continue now on to year 6 to continue our fiscal return ratio, and we'll be completing that shortly this year. Our plans for the future essentially are to continue our plan to cover all GP practices across Mid and East Antrim within our current funding arrangement with the Dunhill Medical Trust and the Health and Social Care Board here. And also we have been contacted by the Impact Project, another Impact project, which is a £15 million UK Centre for Evidence Implementation in Adult Social Care, situated at the University of Birmingham and funded by the Economic and Social Research Council and the Health Foundation. So they want to work across England, Northern Ireland, Scotland and Wales to support the use of evidence such as ours and improve services and lives. Finally then, in Northern Ireland itself, we have had the establishment of the Regional Social Prescribing Board here, which shows that all the main models of social prescribing here in Northern Ireland are represented there, and we sit together along with the Department of Health and the Health and Social Care Board, and that shows a real impetus here to look at a more strategic and coordinated approach to allow social prescribing to grow and develop here, and hopefully to establish that minimum data set that was discussed in the previous presentations. So that is me. Thank you so much for inviting me along today. Apologies about the video, but hopefully you can go online and have a look at that in more detail. Our website's there as well, and there's more evidence and more videos on there that show our project in action. But thank you so much for having me today.
Thank you very much, Sarah. And actually, I thought it was a silent video to begin with, you know, just visual images, which were very helpful for me, actually, not having seen this before. So thank you to all our speakers, and now we have a space where the floor is open to anyone who wants to ask questions, and we'll start off by looking at what's been put in the chat box, whether we have any comments or questions there. Mary, is there anything there specifically for Sarah initially?
Nothing's come in for Sarah yet. I'm sure people will sort of watch it and then think about it. There was one that came in actually for Damon, so perhaps I can go to that one whilst, you know, we invite people to put any other questions or comments in that they've got. Damon, someone was asking that, you know, financial situations and debt's very emotive, and how have patients responded or reacted to getting a text message and being contacted that way?
Yeah, so reasonably well. I mean, it's varied, and we've tried a number of different ways of explaining the project through the text message. We initially didn't have the website set up, so there wasn't an awful lot more information available other than what was in the text about the service. But we were still finding we were getting a sort of hit rate of about 6% off that. Since then, we've built the website, so the text message now directs people to that, and there is more information on there about the sort of support that they can get. So that's proving quite helpful, and through the website we're actually gathering quite a lot more information about the types of problems that people are experiencing, which is then given to the link workers, the financial support link workers, in advance of their first appointment. So that's quite helpful as well, because it means that the financial support link workers don't start the appointment cold without knowing anything at all about the kinds of problems that people are having. So we think that that's going to improve things, and the signs of that are encouraging, although the website only went live about a month or so ago. And similarly, we've redesigned the service leaflet, so there's a lot more information now available within GP practices, posters in practices and the leaflet in practices, so people have got a chance to maybe find out a bit more information about that. And we've also had the posters translated into community languages. We're able to provide some translations on the website as well moving forwards, and on the leaflet too. And we've tried text messaging in community languages such as Portuguese as well, and that actually got quite a big hit rate in comparison with some of the other stuff. So I think generally people have been reporting that they found it very useful to have this service attached to their GP practice, that it is something that they've welcomed. And as I said before, it's not that we're picking up people who are already engaged with getting advice about their financial problems. In the main, we're finding that people have not sought debt advice, they haven't sought advice about their benefits issues before. So we are reaching people for the first time. in that respect, which is very encouraging.
Thanks very much, Damon. I think that's really useful. Sarah, can I ask two things? One is, do you mind stopping sharing your slides now, if that would be all right? I'm sure Janet probably wants to ask about that return on investment, but can I just sneak in and just say that what was really fascinating about your return on investment at the end of their presentation was the community pharmacy return was really sort of at least double, wasn't it? And I wondered what your thoughts are on why that return on investment's looking so good.
So yes, they conducted their own they conducted their own evaluation, essentially to look at how effective the commission services that they have through community pharmacies, such as the minor ailments scheme, the smoking cessation, etc. How effective that would be through the project itself, because it was a huge departure for community pharmacy to be involved in a project like this, and it's obviously a very timely thing. Unfortunately, because of the pandemic, things did slow down for community pharmacy, but they have an organisation here called PACT, and they basically help to bring community pharmacists together in a locality. So essentially it takes away the laborious nature of being able to connect with individual pharmacies. So PACT basically do the logistics for them. And so their financial return on investment was extremely effective, and that's down to the delivery of services and to the healthy working relationship that we were able to provide between them and the GPs, which they had never had essentially before. You know, they may have worked in a similar building to each other, but they've never had that opportunity to sit around a table together and have protected time to discuss a patient's pharmaceutical needs alongside their conditions. Wow, that's really it comes back to that conversation, that collaboration, that relationship again, and you know, it's really brilliant, isn't it? And actually to see that real impact coming out. So thank you for that. There was a flurry of questions that came in, and I just want to go back to Anna and Laura. So we've got a question saying it's really interested to see how Anna and COB are helping make primary care a first destination for clinicians who learn more about prevention in early training through placements in social prescribing. Maybe that wasn't a question, maybe that was a comment of they're really interested. But how difficult has it been to make primary care that first destination?
Sorry, Marie, what do you mean?
So just setting all of that up, how difficult or easy has it been to make this model come together to make primary care a first destination for clinicians to learn more about prevention in early training through their placements?
I think you know, we've been really lucky to work with the University of Chester to host our student nurses, and I think actually even the university has being astounded by the breadth of offer there is available in the third sector to support those clinicians understand and really see the clear parallels between poor health and some of the socio-demographic issues that we demonstrate to individuals. So it's been fantastic. We've been really lucky to work with some really progressive primary care network staff, and the more we are able to do and the opportunities to try something and reflect whether it works or not enables us to take that forward across all of the primary care networks on the Wirral. So I think it's a really exciting time. The pandemic has obviously thrown some challenges at us, but it's also thrown loads of opportunities at us. So we grab those where we can.
Brilliant, thank you. Really good to hear the words progressive and primary care network in the same sentence. There are a huge number of progressive thinkers out there, and I think what I'm noticing this morning is the maturity now of collaborations and what's being achieved and how much of an impact it's having. Sarah, can I come back over to you? We had a question saying, could you explain the wellbeing model you use a bit more? Is there a list of questions you use to help establish a picture of the factors affecting the individual? And could you share that with us, if so?
There's not so much a list of questions, because it is a very personalised intervention. Essentially, every referral, every person that we go to visit, it's very unique circumstances. We use my Impact Age Well plan, and we have developed it around the social determinants of health to ensure that we cover all of those points with that older person, and to make it relatable to them, to help essentially to increase their health literacy and help them to understand what in their life may be affecting their ill health. So they may not understand, from that example that I used about the lady with the front door and the money concerns, and she may not be able, unfortunately, to understand through various different reasons why that would be affecting her sleep. So she's not going to be able to communicate that to her GP in a 10-minute consultation. However, through our the way the plan is essentially a guided conversation, it means that our officers can make sure that they've, not only when they're in the property, because during COVID we had found that we had to obviously revert to telephone support for a certain length of time, and that was extremely problematic because you haven't got your eyes on the situation. You can't look around you and survey the person's home and the way they live themselves. So the plan was very useful then, because we could go through all of those different areas with the person and chat with them through those case studies and explain to them different scenarios that had happened before, and then they were able to join the dots themselves. And in doing so, then we also hope to empower them for the future, so that whenever we leave them at the end of the support, that they will be able to take that ideas and those situations that they've learned from and translate them into what may be affecting their health.
Thank you very much for going into more detail. I think what I hear there, I think is so important, is that idea of my front door doesn't shut properly. There's no connection to the issue of sleep, and then that poor sleep is so detrimental on health. It's unreal, isn't it? So really important bridging those gaps. One new question's come in, but can I just say we had a woo-hoo for involving Portuguese, and I just wondered, maybe we've got 4 or 5 minutes left in the session. Are there any other languages that are being involved? How easy is it? So in Northern Ireland, for instance, does anybody speak Irish at all as native speakers? Or Laura and Anna, are there any other languages in your area that you think need to be represented in the information that's out there? Just wondered what the scope was.
We would have a huge population of Eastern European families and communities in our area of Northern Ireland, so most of our health promotion material, everything would be done in maybe Polish, Romanian, and languages in that area. Also down in the southern area of Northern Ireland, not in our area, but in the southern counties, it would be a huge Portuguese population down there, yes. We would find it quite difficult, and it's not because of language, it's a cultural divide that means that we can't really communicate with older, or we're trying to, but it's been difficult to engage with the older adults in those communities, and that's essentially because they have a great support network and possibly don't need the same support as the Northern Ireland residents.
Brilliant. Laura, Anna, or Damon, any thoughts on that?
Well, just briefly, I mean, Arabic. I can tell you now that actually getting a poster translated into Arabic is not straightforward, but it is definitely worth doing. So I think but there are issues. I mean, obviously, there's little point in advertising the service in foreign languages if you've not got the language capability within the service itself to then deal with that. So we're fortunate in that we've got both Arabic and Portuguese speakers as financial support link workers, so that obviously makes a difference. And citizens advice, I think generally, Anna can correct me if I'm wrong, have access to a language line which enables multiple languages to actually be dealt with through that service. So those are the issues we're grappling with, and we're just trying to see whether it makes a difference in terms of take up and whether it makes a difference in terms of engagement with the different communities.
Thanks very much. So we're just coming to the end. I'm conscious that we started a little bit late, and I think it'd be good to finish at 11:45. So there are a couple of more comments coming in. Thriving communities, they were saying they're working across 13 languages. So there's a lot of way to connect with other delegates who are also, widening this out. We asked for a reference for the return on investment report, Sarah, so we'll get that from you and get that as for Deborah Westlake. So Janet, perhaps I can hand back to you for the final minute or two and thoughts.
Yes, this has been so interesting. I wanted to ask whether there's any last brief word that any of our speakers would like to leave us with, any big takeaways or anything you weren't able to talk about during the session itself that just occurs to you. Can I go around in order just to make it easy for people? Laura, is there anything you would like finally to wrap up?
Sorry, I can't unmute.
We can hear you.
You can hear me. Oh, brilliant. No, just to say thanks so much for the opportunity to speak today. There are various resources about our Health Justice Partnership work on our website for anyone who's interested.
Thank you, Laura. Anna?
Yeah.
Any last thoughts?
Well, just to say, social prescribing is out there. There's an awful lot of pressure on us, I think, to be all things to all people, and we need to stay true to what it is that we are able to do and work in partnership with those organisations that can provide that specialism, like we've identified with Maternity Action today. But keep waving the flag, keep shouting about what we've been able to do, and those opportunities to be innovative will come forward.
Thank you very much, Anna. Damon.
Yes, thanks very much, Janet, for the opportunity. Just reflecting on it, I mean, I think what we're picking up is the importance of face-to-face services, and obviously link workers do need to have services to refer to, and we're particularly dealing with people who are likely to be digitally excluded. The point's well made by Sarah actually about the importance of home visits and face-to-face contact, because you pick up on an awful lot more issues when you can actually see a person in front of you than you do by just talking to them on the phone or by expecting them to get digital advice. So I think the concern at our end is that in terms of debt advice, the national strategy for money and pension services to move towards digital or call centre operations was actually what we're seeing with people with health problems in deprived areas is they need face-to-face provision.
Yes, thank you, Damon. I think that's right. And Sarah, final word from you.
Yes, just to thank you for inviting me along to speak specifically on the topic of health inequalities, because it's something that we feel very passionate about at Impact Agewell, that our form of social prescribing, directly reduces health inequalities, and that's what we set out to do. But also, as Damon says, just the older people live with so many barriers, and that the world has advanced so much in the last 2 years, and so we worry about the landscape, and we worry about the community as well, and the assets that we have in the community are key to building that better world for older people.
Thank you very much. Thank you to all the speakers, who I think we can agree have been brilliant. Thank you to all of you who've put questions and listened, and we'll hand over to the next part of the programme.
Thanks very much, Janet, and really a big thank you to you as well for your wonderful chairing and keeping us to time. So we're going to take a break now. We're about 10 minutes behind, but we're going to aim to start about, I think if we start at 12:10 for the next session, I think that's 5 minutes later than it should be. So we'll lose 5 and gain 5. But thank you very much, everyone, for joining us this morning. Delighted to have such a wealth of knowledge with all our speakers, and yeah, go and take a well-earned break and a stretch of the legs. Thank you.